The first guideline has to do with dominance, whether a patient is dominant or non-dominant side is affected by the hemiplegia. In this scenario, a right spastic hemiplegia is documented with unknown whether the patient's right or left hand dominant. So our guidelines tell us, should the affected side be documented but not specified as dominant or non-dominant, you're going to follow this classification system. If the right side is affected, the default is dominant. That tells us that the fifth character in our code would be 1 indicating right side dominance. In the next guideline, hemiplegia affecting the left side of an ambidextrous patient, the guidelines tell us for ambidextrous patients the default should be dominant. What that means is that if they're ambidextrous, both sides are equally strong. So whatever side is affected, in this case the left side, we're going to say the left side is dominant. Now let's talk about general coding information in this next coding guideline. We can use codes in category G89 along with codes from other categories and other chapters if the G89 code provides more detail. For example, if the scenario given to us does not tell us if the pain is acute or chronic and we have G89 codes that say so, then we would use those G89 codes. If the pain in your documentation is not specified as acute or chronic, not specified as post-thoracotomy, post-procedure, or neoplasm related, we do not assign codes from category G89. It has to have those terms in order for us to use that category. Also, a code from category G89 should not be assigned if the underlying diagnosis is known unless the reason for the encounter is pain control. We'll go over a few examples of that to get into more detail. A little more coding information. If an admission is for a procedure aimed at treating the underlying condition, the underlying condition is the principal diagnosis, not a code from G89. Oftentimes, pain is integral to any procedure or surgery. So unless the physician has documented that the pain is in excess of what one would expect, we would not very often code pain. So we really have to pay attention to documentation. Here's an example of when we could use G89 category codes as our principal. The patient presents for a steroid injection for control of pain of a chronic right knee due to primary degenerative joint disease, also abbreviated DJD. When you look up DJD in the index, it takes you to osteoarthritis, so you can just go osteoarthritis when you see that medical term used, DJD. In this case, though, the patient's presenting for control of pain, not for treatment of the DJD. So the G89 code would be the principal because the patient's presenting for control of the pain. If you think about a lot of the guidelines, it really is what is the encounter or what is the admission for. Depending on where your treatment is directed is going to help you determine what the principal diagnosis should be. The guidelines help you with that as well, but if you can just keep that in mind, it's where's the treatment directed. It helps you really decide what the principal diagnosis should be. In this scenario, the patient is seen to evaluate chronic left shoulder pain. You're evaluating the pain. What the guidelines tell us is that G89 would be used in conjunction with codes that identify the site of pain if the category code provides more information. So even though the patient's being seen to evaluate the pain, that pain in the shoulder is going to be the principal diagnosis, but the pain in the shoulder does not tell the doctor or the reader if the pain's acute or chronic. And because we have a chronic pain code for specified sites, we would use it in this example, G89.29. We're using that G89 category code because it provides additional information. When you are looking at the sequencing of codes with site-specific pain codes, again, it depends on what you're being seen for. This is telling us the patient is seen for management of acute traumatic right knee pain. The patient's being seen not to treat the knee, but to manage the pain. So the pain code, acute pain due to trauma, would be the principal diagnosis, and the pain in the joint would also be there to identify the site. The coding guideline tells us how we would sequence those codes. Assign the code from category G89 followed by the code identifying the specific site of pain. Here's another example. Tests are performed to investigate the source of the patient's chronic epigastric abdominal pain. The pain is being investigated. But because we don't know a diagnosis, we would code the symptom from Chapter 18 in our code book. And there is a code for upper epigastric abdominal pain. We would also add the G89 code because that tells the doctor and the reader that the pain is chronic. Now some general information about postoperative pain. The provider's documentation should be used to guide the coding of post-op pain, as well as information contained in your code book in Section 3 and Section 4. Please take the time to go there, read the guidelines. Those are at the beginning of the code book. Read through those times when we would report additional diagnoses or when we're reporting in the outpatient setting. As I mentioned earlier, pain is associated with a procedure most of the time, but we still have to be cognizant of the fact that there's time we would want to code it. The default for post-thoracotomy and other post-op pain not identified as acute or chronic is to use the acute form of pain, not the chronic form of pain. Routine or expected post-op pain immediately after surgery should not be coded. Here's an example. Patient's pain pump. The dosage is increased for unexpected extreme pain post-thoracotomy. There is a pain code for post-thoracotomy, and the default one, because we're not saying if it's acute or chronic in this scenario, would code it. I can't imagine how much that hurts because you're actually going through the patient's chest, often going through the ribs, so it would have quite a bit of pain associated with a thoracotomy. That's why there's a unique code for it. I bring this slide to your attention just to point out the chronic pain and chronic pain syndrome, central pain syndrome, those are different things. So be very careful in your reading of documentation that you are picking up the right terms. With regard to chronic pain, there's no time frame with that. There's no definition of if your pain's lasted more than a year, now it's classified as chronic. There's no documentation or no guidelines around that, so you're just going to depend on your provider's documentation to guide your use of the code for chronic pain. Chronic pain syndrome, G89.4, and central pain syndrome, G89.0, are different than the term chronic pain. So if your documentation states those things, you would be looking specifically for those diagnoses and not a chronic pain diagnosis. It also refers us to Chapter 5 in the guidelines in the code book for pain disorders related to psychological factors. Sometimes chronic pain is believed to be related to psychological factors where you would be adding that F45.42 code. Now let's talk about pain related to malignancies or neoplasms. Code G89.3 is a code that specifically states pain due to cancer, pain due to malignancy. It doesn't matter if the pain is acute or chronic in those cases. If it's related to malignancy, you're just going to add it to document the patient does have pain related to the malignancy. If the pain related to the malignancy is the reason why the patient is being treated, that would be your principal diagnosis, and the cancer diagnosis would be reported as an additional code. If the reason for the admission was to manage the neoplasm, but the patient has pain associated with the neoplasm, that code G89.3 would be assigned, but it would not be the principal. The principal would be the code for the cancer. And then in italics, it refers us back to the neoplasm chapter, Chapter 2 in the code book, to review those guidelines as well. Here's an example. The patient is admitted for pain medication adjustment for chronic pain from bone metastasis. The admission is for the pain due to the malignancy. So that would be your principal diagnosis, G89.3. We would assign the bone cancer which if it's a metastasis, it's a secondary malignant code. So going to the table of neoplasms, you would see bone and then the column that says secondary malignant, and that would be C79.51 would be your additional code or your secondary code. Notice again that the reason for the encounter or the admission is what determines your principal diagnosis. In this example, the patient with lung cancer presents with acute hip pain, evaluated and found to have iliac bone metastasis. So the pain is being evaluated, but really it's the cancer that's driving the admission. So the secondary malignant bone cancer would be your principal diagnosis, followed by the primary malignancy code, and then the pain due to malignancy. And if you remember from a previous guideline, it doesn't matter if it's acute or chronic if it's pain related to malignancy. You just state the G89.3 code. If you have any questions about the Chapter 6 guidelines, please post them in the discussion board. As with all of these podcasts, I encourage you to watch them more than once because I'm hoping by hearing them, you will be reminded when you're doing your homework that there is a guideline related to those things. Also, as a reminder, I don't cover all the guidelines in the podcast. They would simply be too long, but I am hitting on those that we would find most often in acute care. Thank you so much, and have a nice evening.